Now we will move to session 4, Technologies on the Ground, adapting new technologies in the context of LMICs. For this session, I'd like to invite Dr. Peter Warner from Bill and Melinda Gates Foundation, Dr. Jeremy Barrows from Medicines for Malaria Venture, Ms. Mariko Kitahama from NEC Corporation, and Dr. Keita Wagatsuma from Niigata University. Dr. Kiichiro Kobori from the GHIT Fund will moderate the discussions. Kobo, the floor is now yours.
Thank you, Naoto, for your kind introduction. I am Kiichiro Kobori from Partnership Development of Investment Impact. I'll be the moderator for the fourth session of today. Please call me Kobo. We have a fourth speaker in this session today covering technologies on the ground, adapting new technology in the context of the LMIC. Speaker will be given the presentation first, followed by the panel discussion, where we'll be taking some questions from the floor as well. So to set the stage after the networking game bingo, let's take a quick poll. So ready? So how many of you have personally seen the technology being used in the low resource setting? So raise your hand. Nobody? Oh. Question is, how many of you have personally seen the technology being used in the low resource setting? Raise a hand. Oh, great. It seems we have an audience ready to dive into this session. So please allow me introducing the Peter from the Bill Gates. Peter, please, it would be great if you could start your presentation. Please keep it within 10 minutes.
Okay, well, thank you very much for the introduction. And it's great to be back in Japan. I spoke at this meeting in 2017, and it's good to be back. So I'm going to talk a little bit about the work that we support and drive and lead from the Gates Foundation's perspective. So starting off with the Gates Foundation and some of the principles that drive what we do, very much the foundation is focused on developing new technologies, but not just new technologies for their own sake, but new technologies which can be impactful in the geographies where we believe we can make a difference to people's lives. So I think it really fits well with the theme of this session. And you can see some points on this slide. It's very important to generate good quality data so that we can figure out what is the problem. And when we do have an innovation and a tool and we implement it, does it really make the difference we hoped? Market incentives, in many cases in these geographies, there isn't a strong market, and so the Gates Foundation tries to do what we can, where appropriate, to get around the issues of market failure, so that the people in these geographies can indeed benefit from technologies. Innovation, I've talked about spurring innovation, that's in our DNA at the Foundation, working with talented partners across the globe, including here in Japan. And collaboration. Collaboration is critical for what we do. We need to make sure that sitting in Seattle or Tokyo or wherever else we are, that we really collaborate with the people who are going to be being impacted in the low resource settings, and make sure that we are fully in tune and that whatever we do in an efficient way as possible. So in the Discovery and Translational Sciences organization section at the Gates Foundation, we focus on vaccines and biologics, drug discovery, that's where I sit, reproductive health technologies. We have a whole group of people building partnerships globally, particularly in the global south. We have a team that looks that ensures that the technologies that are available can be made easily accessible to our partners and our grantees. And the translational science is a very important aspect of what we do, bridging the gap between the upstream science and technology and then the downstream clinical impact. This slide really is just an illustration of some of the work that we've been doing over the last few years. I think everybody has been, at least I was very surprised at just how quickly artificial intelligence and the large language models and so forth have really almost kind of revolutionized what we're doing in some spheres of life. And I think in drug discovery, there's been a lot of hype about what AI and machine learning can do. And I'm not sure whether all of that hype will actually get the benefits that we're being told. But nevertheless, I think there's something here that's going to be very important for drug discovery. And we want to make sure that the Gates Foundation is able to harness that so that we can benefit, the people living in the low and middle income countries, in the low resource settings, can benefit from this new technology revolution that we are seeing now. So we've made a number of investments. We're learning about how this may impact on our drug discovery and beyond that, also implementation in the field. It's a huge area that we're building right now. We're also very keen to make sure that these tools don't just remain in the hands of biotech companies that will inevitably charge quite high prices to access their technology. We want to democratize this, and I think Jeremy will be talking more about that. I'd wanted to touch on one of the, it's a sort of, we consider this to be an innovation in the sense of how we work, and it very much feeds into this theme of collaboration. So when it comes to developing new drugs, it's an expensive business, as we all know. And there's a lot of failure, unfortunately. When we are working in global health, we need to make sure that given that resources will be quite limited, that what we do is done efficiently, that we do not tolerate unproductive duplication, and that people are able to work together to generate the best science and the best products ultimately. So we do this in areas, for example, such as tuberculosis, where I think most people, if not everybody, would agree there's a market failure. You know, there's not money to be really made from TB drug discovery and development. So more than 10 years ago now, we built this TB drug accelerator concept. And the idea is that we do the TB drug discovery and development in a consortium where people share the information from day one. So what is the TB drug accelerator? Well, as I say, it's a consortium that was created to drive cutting-edge drug discovery alongside investments in innovative technology platforms that inform the selection of targets, optimization of drugs, and building of drug combinations. I think, as we all know, TB is treated currently with 4 drugs, and we expect and we anticipate going forwards that we'll always need to put together combinations of drugs to treat tuberculosis, to prevent resistance, and so forth. So the way that the consortium works, and it consists of pharmaceutical companies, and you can see there that includes Japan, non-profit research institutes, and also leading academics in the field of TB. We're very fortunate to be able to bring together, and I think in a way that when I was working in the pharma industry, I would have been very jealous of, bringing together people with enormous capabilities, not just in drug discovery, but also in the basic science. Within a collaboration and sharing agreement, the teams involved share the biological and chemical structural data from day one within the consortium so that we can take the best hits from screening, which is usually derived from screening pharmaceutical company collections. The best hits can then be optimized through to drug candidates. And that way, we should be able to avoid unproductive duplication or futile efforts. It's been relatively successful. I think we deliver 1 clinical candidate per year into clinical development from this consortium. Currently, we have about 20 hit-to-lead and lead optimization projects and about 20 earlier stage activities. And this picture here shows where some of the more advanced candidates have got to. We're talking about innovative technologies and how that impacts. One of the issues with tuberculosis is that we believe that it's important to be able to shorten treatment therapy from the current 6 months down to something more like 1 or 2 months, ideally. So how do we do that? Well, it's a combinatorial issue of combining different modes of action, different drug candidates. So what we've done over the last 10 years, and I think, or I say we, the people that we're funding, the scientists involved, what they've been able to do is to be able to develop checkerboard technologies in a way that really builds on and significantly takes forward what's currently previously been done in that area, in vitro. So we can look at the potential of combining drugs in vitro. But that's only the starting point. We need to make sure drugs get into the TB granulomas. We develop technologies for that. Once they get into the TB granulomas, those compounds need to be able to kill the MTB, which is often adapting itself metabolically and becomes quite resistant to drugs. We need to be able to measure that. We've got the relapsing mouse model of TB, which is our sort of gold standard for being able to determine how long a regimen of drugs is going to be needed to be given to treat TB. So we combine that, we combine all that data together using some AI machine learning modeling. And that gives us a prediction for a particular regimen of how long it's likely it's going to take to cure in the clinic. Now, we've got one proof of principle here with Study 31, which was designed in this way and indeed did lead to a reduction from 6 months to 4 months. So in the time I've got available, I would just like to throw this up. There's lots of detail here. Really, the main point of this is to say that through this TB drug accelerator and working together on these with this science, we've developed a better bedaquiline candidate we think could really build on bedaquiline, which is a fantastic drug. We've got a better linazolid, which seems to be very effective in certain types of TB. We've got novel protein synthesis inhibitors, and there's a compound there from GSK, and we've got modulators of cholesterol metabolism. And this is new science that's emerged, and the last one in particular, seems to be particularly good at reducing the duration of TB treatment required. And just to finish off, I just wanted to emphasize that in order for us to be successful in delivering really impactful therapies that are going to make a real difference to those people in the low and middle income countries, we have to work globally in consortia. We've got the TBDA, that's the engine that's delivering many of the clinical candidates. We've got PAN-TB, which is putting them together into initial clinical trials. There are a number of other groups that are working on developing and delivering clinical trials beyond phase 2 and into phase 3. And this ecosystem that's really developed over the last 10 years in particular, I think really sets us up well for being able to get much better treatments out there for the patients in the low resource settings that really need these drugs. As Sam was saying, TB is difficult. We are making progress. We need as many more partners that are as prepared to get involved with this as possible so that we can be successful. And that's one of the reasons why I come to Japan frequently and why I've engaged with GHIT, which has clearly a strong mission to make a difference in TB as well. Thank you very much.
Thank you, Peter, for your presentation. Thank you for the eye-opening talk. It's so amazing to see how cutting-edge science like generative chemistry and AI application is translated in the impactful solution for the LMIC by partnering or a consortium. So it's definitely food for thought. We consider how to adapt these technologies more broadly or into the LMIC. Thank you. So next speaker will be Jamie of Medicine for Malaria. So Jamie, it would be great if you could start your presentation. Please keep it within 10 minutes. Thank you.
Thank you, Kobo. It's a real honor to be here. Thank you. So I'm going to be talking about adapting new technologies in the context of LMICs. And this, indeed, everything we do at MMV is in the context of malaria and the challenges faced by people living in malaria endemic countries. So at MMV, we have 4 segments to our strategy. The first 3 are all focused on malaria, curing patients, preventing infections, and eliminating malaria. And the fourth is focused, for example, on tools such as machine learning that could apply to malaria but also be beyond malaria. We have a range also of cross-cutting priorities and values. And from a discovery perspective, I want to particularly pick out the embracing equity and then driving excellence and impacting equitable partnerships. Okay, so I'm a discovery guy, and with our partners, we've built a very robust process focused covering all of the phases of drug discovery, from creating a new technology to screening, to find small molecule active hits, and then to optimize these towards candidate drugs for further development. And I put on the GHIT Fund RFP platforms as a frame of reference. So the key point is that at the transition of each of these phases, we have milestones and we have quality criteria associated with these. And so, for example, at preclinical candidate, we have a standard of excellence which is expected of all of our candidate drugs, regardless of where the work has been actually performed. So a drug discovery team working in Ghana or a drug discovery team working in Japan or Europe, we expect the same level of quality. So how do we actually work with partners to deliver this quality? Well, the MMV model is a little bit like being at the hub of a wheel with spokes reaching out to our partners. And we work with teams, with principal investigators who are the project owners and the project leaders, but these PIs do not work alone. And the MMV team, who we are scientists, we collaborate closely with the project team and are able to bring in expert input and connect to our wider network. Obviously, if a project team is based in Africa compared with based in Japan, there will be a very different level of involvement and interaction. And this model has been successful. So globally, including from projects within Africa, we've delivered over 30 candidate drugs in the last 15 years. And I want to particularly thank all of our discovery Japanese partners for your wonderful collaboration. Okay, there are many challenges doing discovery in the context of malaria. I've put 4 on this slide, but I'm going to focus on the first and the last, optimizing half-life and dose, given our target product profiles, and then actually how can we harness machine learning for global health. So first of all, target product profiles. So these are the profiles of a product, of a medicine, which, if met, meet the needs of both the patient, the healthcare provider, and also the payer. And in the context of malaria endemic countries where there is the factor of poverty, of poor infrastructure, of fragile health systems, these put demands on the target product profiles that we need to deliver. Paul mentioned about the target product profiles we have for treatment and prevention, and these have major challenges, particularly around delivering compounds with long half-life, pharmacokinetic challenges. As I said, our teams are not alone. What we've done is we've worked with pharmacokineticists across the world and state-of-the-art equations to develop open access pharmacometric tools. And these are delivered to equip our scientists working in global health and in LMICs, and to support the medicinal chemistry decision-making on unbound pharmacokinetic and pharmacodynamic parameters. And in particular, to help teams, even in the lead optimization process, to actually get early predictions of human pharmacokinetics and dose, so that that can actually be integrated into their optimization. And on the left, you can see just a snapshot from a tool we very recently delivered called MMV-Free, which is helping teams at the very start of the test cascade. And then on the right, MMV Solar, which is a tool that's been around for a few years now and is helping teams with these early dose predictions. So how can we harness machine learning for global health? Well, we can start by using the data that we have. And in the malaria community, we've been fortunate to screen a lot of compounds with our partners in phenotypic assays. So what we have done is we've worked with a number of our pharmaceutical companies to actually build a consensus Bayesian neural network model, which we've been able to place on the Kemble website. This is free, open access, and allows any scientist to upload a chemical structure and get a prediction of the likelihood of that compound having an enriched likelihood of being active in malaria. And that compound can be real or it can be virtual. And that can obviously give answers to all sorts of questions that scientists will have. Machine learning is also very powerful in the context of pattern recognition. And we're really excited to be exploring cell painting. So this is where we are looking at parasites in blood in well plates, where we add dyes and we stain an image at different time points in the presence and absence of compounds with known mode of actions. And we can then train algorithms to actually recognize the pattern that is observed of the image compared with the mode of action signature. And this is extremely exciting because at the moment it takes us months to deconvolute phenotypic actives from a high throughput screen. This would take this to a matter of days if it delivers. And finally, the open access design tool, and this is something that Peter mentioned. So this is really bringing generative AI to global health. This is not just a malaria tool, this is relevant for all pathogens. And this is an award that the Bill and Melinda Gates Foundation have granted us to deliver. The concept of the tool is to allow scientists to upload chemical structures, biological data, which is then modeled. Then there is generative design, where in silico structures are created and scored against the model. And then because we build global models of physical properties, of pharmacokinetic safety, using our data and public data, we can then filter. And then there are algorithms for predicting how easy a compound is to make, and also how to maximize the learning once we've made the compound. So the idea is that these compounds are made and tested, and the data is then fed back in a learning loop. So we will be delivering this in 2026. I believe it will democratize machine learning in drug discovery and equip LMIC scientists, not least because tools, commercial tools, are extremely expensive. And because of the improved quality through prediction and the active learning, this should shorten drug discovery timelines and reduce cost. So in summary, MMV works with partners globally to deliver next generation medicines for malaria. And I want to just give a huge shout out to our Japanese partners and to GHIT Fund for all of your support. Thank you. We've got defined process and criteria which we're using to support our teams with open access tools along with training. And we have challenging target product profiles, but these are achievable, and we have strategies to aid our teams in delivery. And we're integrating machine learning into the discovery workflow, which I believe will be a force for equity in global health research. Thank you very much.
Thank you, Jeremy, for your presentation. Your presentation is thought-provoking. I'm sure many here were impressed by the MVP consequence, QSAR model, and cell-painting approach and tool that could inspire new direction for us for the global health. Thank you. So next speaker will be Mariko-san, Mariko-san, so from the NEC Corporation. So Mariko-san, it would be great if you could start your presentation. Please keep it within 10 minutes. Thank you.
Yes, thank you, Kobo, for your introduction. Hello, everyone. My name is Mariko from NEC Corporation. So, my presentation will be composed by two parts. The first part would be the introduction of NEC and why we are doing this activity. And the second part is our use cases in global health sectors. So this slide, NEC at a glance, has a lot of data to show who we are, who NEC is. But simply saying, NEC is IT company based in Japan, having a lot of footprint all over the world with its history over 120 years. And more importantly, in this presentation, as a right bottom, we have our corporate statement, brand statement that is orchestrating the brighter world. We incorporate our commitment into this message to create a society where everyone can have a chance to reach out their full potential. So how to realize our corporate brand message is one of our initiative is using the approach, the digitalization for leave no one behind with 4 steps. The first step is personal identification. So that is idea to provide ID to everyone so that everyone can be recognized by the government and to receive the essential social services. And the second step is about provision of the humanitarian aid. Well, this is for people in need to receive the emergency assistance as a timely manner. And the third step is the capacity building for everyone to be independent economically and socially. So we aim to repeat this process with inviting all stakeholders, including the international societies, local communities, and local governments, and everyone. So let me move on the use cases. I'm going to show 4 use cases from now on. And the first one is a collaboration with Gavi for the step 1 personal identification. So this one was the POC in Bangladesh for the MR vaccine delivery. Well, previously, the healthcare workers use a booklet to register and record all the historical data for the mother and children. But it takes more than 20 minutes to write down all the necessary data onto the booklet and also look for the historical data from the booklet too. So what we did is to develop the fingerprint identification technology for toddlers, and we do the verify and register and the children and also its data into the system so that the operation hour can be very quick, like 19 seconds for the registration and verification. So it really helps the operation for the healthcare workers. And the second case is for together we did with FAO in Mozambique for the step 2, the provision of humanitarian aid. So traditionally, the international organizations or local governments, they do use the paper-based vouchers for distributing the subsidy programs. So, but sometimes if the voucher is intended to give the medical equipment, so mother receive the voucher and kept it at home, it's like $10 or $20 voucher, then the father can find out that voucher and he can say that, oh, here I have the extra $10 or $20, so let's buy an extra beers for himself. So that happens. So in order to avoid that situation and in order to deliver the necessary items for intended people, we set up some system for the digitalized vouchers. So that digital vouchers has some personal verification functionality so that we can deliver it, and the people just only bring the IC card to the kiosk and do the necessary data transaction in the tablet. So for the local organizations, they can monitor and make some analysis for the next better subsidy programs using the data transactions. And the next case is our collaboration with WFP. So that is for the step 3, capacity building. Well, we did this case in Ghana to assist the healthcare workers for their health checkup services. You know that health checkup is totally depending on the healthcare workers and their education or their training skills. So sometimes some person is quite a bit difficult to deliver the proper health checkups. So in order to standardize the health checkup to all the same quality to the mother and children, we created the mobile application. In the mobile application, the healthcare workers can see the visualized guideline so that they only follow the way that shown in the application. So that the indicators filled in the application for the health checkup was dramatically increased, and also numbers of the nutrition guideline to deliver to mother and children was also increased. And good for us, with using this application, 90% of mothers can remember what nutrition education they received from healthcare workers because of the visualized images. And well, this is the last slide of my presentation, and that is a collaboration with CEPI. I know Dr. Timothy, you will be having a presentation in the next session, and well, from CEPI, and it is our great honor to work with CEPI. So as everyone has a very fresh memory about COVID-19, well, epidemic or pandemic has quite significant impact in all over the world, especially in the low and middle income countries. Well, when COVID-19 happened, well, actually I was in Kenya, and I see a lot of people are suffering from the COVID-19 because of, they had to close their shops or restaurant, and also they even lose their jobs. So the importance is to prepare for the next coming pandemics. So CEPI kindly launched a program called 100 Days Challenge, and we are honorably awarded for it. So with CEPI, we designed a prototype of the beta coronavirus families vaccines so that we could be ready to manufacture and manufacture the next coming disease vaccination within 100 days. So that is the CEPI project. Well, ADC has our booth at exhibition area. So if you have any questions or comments or discussions in depth, then we are more than welcome at our booth. So let us have a discussion. Oh, thank you.
Thank you, Mariko-san, for your presentation. The initiative shared like a child fingerprint solution and e-virtual system clearly demonstrate how digital innovation can make a tangible difference in equity in global health and capacity building in LMIC. So next speaker will be Keita-san of Niigata University. So, Keita-san, it would be great if you could start your presentation, and please keep it within 10 minutes.
Thank you very much for the kind introduction from the Kobo, and I'm really happy to have this kind of the chance to present to the all kind of the peoples. My name is Keita Wagatsuma from the Graduate School of Medicine in Niigata University in Japan. So actually my major is the environmental epidemiology. So my much of the interest in the health impacts assessment for the climate change. So today I'd like to briefly introduce in some kind of my experience and also some kind of the perspectives on the climate change and transmission dynamics of the infectious diseases and also the human health impacts in low and middle income countries. So in 2021, the IPCC, or Intergovernmental Panel of the Climate Change, and also the Lancet, the countdown for the climate change, simultaneously published in the report on the climate change impacts on the human health. And you can see in this graph shows in the change in the global surface temperature, I mean the future scenarios based on the temperature rise. And now we are facing in around the 20s, and the blue lines shows in the most optimistic scenarios that can successfully reduce the greenhouse gas emissions in the futures. And also, based on the scenarios, in the 1.1 degrees Celsius approximately increase at these centuries. On the other hand, in the red line shows in the most bad scenarios, I mean the business as usual scenarios is the projected in the increase of the temperature approximately the 4 or the 5 degrees Celsius increase at the end of these centuries. But the other scenarios are existing in between. But importantly, we still don't know which courses we'll take in the future is the most important things. So when we looked at also the report from the temperature rise in the futures, and also focus on the frequency of the events, such as the heat event or the cold event or the other events, around 2010, the heat exposures event in the significantly and substantially increased in the worldwide, increasing in also Japan and China and India. This graph with climate change shows the additional deaths due to the climate change. The near future in the 2030s, in the 2050, 100,000, the additional deaths projected, and among this, the heat-related deaths, and the diarrheas and malnutrition and malaria is the most significant things. And when we looked at also the global distribution of the number of the additional number of cases, most significant over the vulnerable areas is the of Africa and also the Asia Pacific regions. And also, most importantly, I want to highlight here and spatial or the spatial temporal the heterogeneity or heterogeneity is we can observe in this figure shows. And I want to introduce the overall the concept of the planetary health, reading the planetary boundaries you can see. And this is a concept, new concept of the limit of the Earth's environment within which humans can survive in the safety. And the most important point is which the risk of the large scale and rapid and environmental change and increase. There are the 9 regions of these planetary boundaries, but recent report pointed out that boundaries has already been exceeded in 6 areas, especially in greenhouse gas emissions related to the climate change. And I want to highlight here today, and half of the world populations are now at risk of the mosquito-borne diseases, increasing the dengue fevers and also the malaria cases worldwide. Here you can see from the Lancet Journal's latest report in 2023 and the changes in the risk of the infectious diseases outbreaks. So in the 1950s, of the 10% of the areas considered unsuitable for the malaria epidemics, but this kind of the epidemic areas expanding in globally, and also the suitable in recent years shown in the orange dots. And also the important, the recent the report is the excess mortality. I mean the excess deaths, number of the deaths due to the diarrhea caused by the global warming is projected based on some future scenario, climate change scenarios. In 1980s and 2095, in the most pessimistic temperature rise scenario, approximately the 84,000 number of additional deaths is projected, so-called in the RCP 6.0 scenarios. So mainly you can see in the maps, you can see in the mainly Sub-Saharan Africa's increased, and also the India's, they're projected in increased number of the mortality, excess mortality. So we are facing with the climate change, and the mitigation and adaptation plans we need to the actions. And environmentally suitable and the climate resilient society is we want to create. We are facing in the increasing of the greenhouse gases in the actuary, and the mitigation plan is needed. And with the climate change is also the global warming is now we are facing. So the additional adaptation plans we need to the actions. Here in the 2021, in the top journal of the New England Journal of Medicine and the British Medical Journal, and also the Lancet Journal is published in the latest report of the call for the emergent action to limit the global temperature rise increasing. So this means we need to rapidly take the actions in the globally and the locally, in the regionally. We need to do some actions. This is some summary of my brief perspectives. So we want to highlight again the health effects of the global warming are already occurring. As you can see, maybe as you know, the COP29 in 2024 in the Baku also gathered about the important issues. The developing and the developed countries, the discrepancy of the discussion exists. So we need to more the communication with each others. And also all regions will be affected, but the most significant effect are predicted in low and middle income countries. We need to focus on some regions to assess the burden of the diseases. And also the adaptation measures in addition to the mitigation measures are necessary. But on the other hand, it is difficult to accurately predict in the future effect. But on the other hand, this means the future can be changed based on our actions. So it depending on what we can do in the future. So thank you very much. This is the concluding remarks for my presentation. Thank you so much.
So thank you, Keita, for your presentation. I would say that's an incredibly comprehensive presentation. The synthesis of planetary boundary, global warming scenario, and health impact offered a powerful framework to understand, address the health challenge by climate change. So thank you for all our speaker who brings such a diverse prospects to the table. So now we are moving into the panel discussion. So I think we have about 15 minutes for the panel discussion. So I will make some questions to each speaker. First, Peter, so in your presentation, you touched on how Gates Foundation invests in science and technology, including AI and machine learning, to accelerating a drug discovery, particularly for the tuberculosis. So from your perspective, how can innovations in technology, both R&D and downstream implication, be better leveraged to deliver a tangible benefit to the patient in the LMIC?
So I think, as I was saying in my presentation, to try and address that question, what we try and do is we develop use cases and target product profiles so that we are developing, in this case, drug therapies which are fit for purpose, which are really going to make a difference to the people who are suffering from TB. So, you know, we need to be realistic about how much burden we can put on healthcare systems, if you like. So we need our TB regimens to be clearly very cheap. The current regimen that's used, standard of care, is quite effective, and it's very cheap. So that's a real challenge, I think, for us. We need to make sure that we're going to make a difference, so it's a meaningful difference. If we're going to get another regimen to be incorporated, to be taken up and used. So you know, we very much believe that having a much shorter regimen is very, very important, and that the regimen should be, to a large extent, free of pre-existing resistance. Now, we're realistic that resistance will occur, but if we can avoid a lot of drug susceptibility testing, that should enable us to get the regimens, the drugs, to patients much more quickly and avoid some of the dropouts that we see. So a lot of people don't get onto drug therapy when they could benefit from it for various reasons, and trying to address those gaps in the cascade of treatment you know, is very important. So trying to bring all that together and listening and consulting continuously with the people in these regions to make sure that what we're doing isn't driven by some sort of high-income country vision of what we should be doing, but is actually rooted in what's needed on the ground. I don't know if that answers your question, but that's very important to us that we develop something that's going to be impactful.
Thank you for insights. Thank you so much. So, Jamie, your question. So, what are the most critical challenge you are facing in introducing and adopting new technology for the healthcare in a low, middle-income country? How have you addressed them?
Thank you. The most critical challenges. So it really does depend on you know, whether it's a project or a tool. Really, as you know, as Peter was saying, and has been highlighted in earlier sessions, it is critical for us to have early collaboration, early feedback from the field. And I can give you, two examples. Paul mentioned about long-acting injectables for malaria. Actually getting feedback from healthcare professionals, from patients, from caregivers, from systems within a number of African countries. This information came back and was amazing in helping us frame the target product profile that we have defined. And in fact, that target product profile wasn't exactly the same as the one that we had originally dreamt up. So it's really, really important that we get feedback from the people who will actually be using the technology. Another example, I mentioned the open design tool. So this is in the process of being created. It's not yet finalized and locked what the scope of it will look like. We are extremely eager to get feedback and to talk to people. And we recently presented this at the African Malaria Modeling Network and had good insights, which we want to follow up on. So I think, Kobo, that's where I would rest. Thank you.
Thank you. Thank you for the good example for to my question. Thank you so much. To Mariko-san, actually, same question as Jamie. So What are the most critical challenges you are facing in adapting new technology for the healthcare in a low and middle income country? Then how have you addressed them?
Well, thank you for the question. I suppose that is very important to share with. I mean, for us to understand the true needs in the ground is quite difficult, and that is one of the important challenges we have to address with. So, in order to overcome that challenge, we do the three steps before, during, and after the implementation of the project. Before, we do the careful interview and consultation with the stakeholders, as well as we do some journey mapping to understand the operation in ground too. So, for example, for the case of the Gavi, with our partner Simprint, we did some observation on the ground, and we just found that different parents bring the same child to the vaccine distribution, because they can receive a small money just like for the transportation fee or so. So they want to get that small money, so they use the same child for the vaccine. But it is totally not good for the health of the child to receive the vaccine in the very short period as several times. So we understand the importance of the personal identification or verification from that observation, as well as our partner went to the clinic, and they see how what the healthcare workers take time during the operation process. So, so that from that we learn that the importance of efficiency of the operation too. So, and during the implementation, we also did some hands-on based project. So so that everyone on the ground can understand why they are doing this project, for what. So, and after the project, what we see the important is doing the evaluation, so to understand what is the social impact we had, good or bad, through this project. So from that, we could have the better program for the next ones. So that is what we learned.
Thank you for sharing the insight to how to implementing the technology into the LMICs. Thank you so much. So, Keita-san, you highlighted the role of the climate information prediction model to addressing a neglected tropical disease like a dengue fever or malaria. From your perspective, what are the key factors that have contributed to successful implementation and scaling of these technology in the LMIC?
Thank you for the covers. Great questions. This is a kind of the much of the important things. Well, firstly, let me introduce some example for the early warning systems for the in the low and middle income countries. And in general, now the South Africa's regions, and for the malaria predictions, the early warning systems are already active. And then also, based on the predictions in the 1 week, on the 2 weeks future number of the cases. For example, in the 1 week after or the 2 week after, how many number of the patient or the number of the cases in specific regions can predict it. And approximately in the 80% or the 90%, only using the temperature or the humidity data. Because the benefit of this kind of the ambient climate data set is we can get using the satellite-based data or the local epidemiological data. So this is a kind of the cost when we in terms of the cost effectiveness, it's really good for integrated in the local regions, and the covers perspectives and the good things and the benefits and the most important things is I want to highlight the two things. First things is the strong partnerships between the researchers, academics, and also the local governments and the local regional governments, and also the international governments. We need to take the actions to achieve the same objectives, and to need to work together and need to communicate each other in the details. And the second thing is to the capacity building in the local regions. As we know, the local regions, it's really sometimes is difficult to integrate it. For example, in the models, projection models cases, in the local regional policy making, it's really difficult because sometimes is policymakers ask me, is it really true or not? But it's really difficult to say it actually how, because the confidence intervals are really, really high. So we need to the more researches and the future research need to more create in the sophisticated models and to predict in the future how many number of the cases in the dengue or the malaria cases in these regions they can predict it. But anyway, the overall, we need to take the collaboration in the local regions. This is my answers, so thank you.
Thank you, Keita-san, to sharing the insight and the importance of the partnership everybody talking about today. So we have 5 minutes to end this session. And I would like to ask the floor to any question to the speaker. Please make sure to mention who you are like to address your question to, or if you raise your hand, and our staff bring your mic. Then please making your name and organization as well. Yeah.
My name is Imad from Osaka University. So I have a question to Peter and Jeremy, and looking for comments. It's about technology. So I think we have to learn from other area of research, biomedical research, like oncology and so on. And now we are seeing in basic research, technology like biodigital twin, for example, is coming on, especially on oncology, for example, for drug development and also to understand the basic pathogenesis of the disease. And also organoid, iPS-derived organoid is also coming, because it could still, you are developing, or we are developing mouse models, for example, for different diseases, but there is difference between human and mouse. But now organoid proved to be mimic the pathogenesis of the disease and can be helpful to get a lot of readouts from these models. So how do you envision this in the future for global health-related and infectious disease, if possible? Thank you.
So thank you. You highlighted important areas, and I won't repeat what you said. We're implementing that sort of technology where we can in our drug discovery programs at the Gates Foundation across TB, malaria, and reproductive health and so forth. One area that has made a big difference in the TB area, actually, and also malaria, is the use of CRISPR technology in order to be able to better understand which are the best targets in the bug or the pathogen to aim at when it comes to new drugs. So, and we can use those technologies to look at the impact of knocking down more than one target in the bug without having to go to the trouble of finding compounds first. I mean, there are some approximations there, but it's really helpful in terms of understanding how to focus our research on the very best targets and give ourselves the best chance of coming up with a regimen that really will meet our requirements. So, lots of area of technology. We try to highlight the use of AI to really improve the efficiency and effectiveness of doing medicinal chemistry and the integrated drug discovery process. I mean, I could go on and on, but the important point is we want to make sure that all of these technologies are available for problems that are important in global health that are going to make an impact in the LMICs. Jeremy.
Thanks, Peter. Thank you. I guess we don't invest in technology for technology's sake. It's really looking to see where we have a gap in, particularly in, in our translational predictions. And I guess we're very, very fortunate within the malaria context that we have already good preclinical models in vivo and in vitro, where we see very good translation. Organoids, I mean, is a really interesting, area, and that has been explored for certain, liver, Vivax liver stages, for example. You also mentioned iPSC. I guess this is exciting in the context of the in vitro teratogenicity screens, and actually starting with iPSC and going out to different, different germlines. And this is an exploratory approach that we're looking to help us find compounds which will have potential in pregnancy. Thank you.
Thank you for the question and some insight, sharing the insight. Thank you so much. So unfortunately, I need to close this session. Thank you again for all the speaker, Peter, Jamie, Mariko-san, and Keita-san. Thank you so much. And thank you for the valuable question. Thank you.
GHIT Fund. Fight neglected diseases through partnerships.